Just a heads up, this episode talks directly about suicide. If you or someone you know needs help, you can text or call the National Suicide Prevention Hotline at 1-800-273-8255. That's 1-800-273-8255, where you can talk to a trained professional and receive immediate support.
Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey, friends, welcome back to this week's episode of the Healing Pain Podcast. This week, we have an important episode. We're discussing the association between chronic pain and suicide. The information you learn in this episode may help you more effectively screen for the risk of suicide. It may help you effectively treat suicide. And just by learning and sharing this information, you may actually save a life. According to the American Foundation for Suicide Prevention, suicide is the 10th leading cause of death in the United States. In 2019, approximately 48,000 Americans died by suicide. And in that same year, there were an estimated 1.4 million suicide attempts. Chronic pain is a risk factor for suicide, and research indicates that chronic pain is present in about 10% of those who die by suicide. It's important as licensed healthcare professionals, as well as loved ones of those who live with chronic pain, that we learn how to ask the right questions, how to assess for risk factors, and how to intervene to help prevent suicide rates. In a few moments, you'll meet clinical psychologist Dr. Joan Rosenberg, who has conducted research in the field of suicide as well as treated patients in her clinical practice. But before we begin, I wanted to provide you with some information so that you can effectively ask, assess, and intervene in those who you feel may be at risk for suicide, especially those who live with chronic pain. What I'd like to do first is just provide you with a short list of factors that may increase the risk of suicidal behavior among people living with chronic pain. And if you're a healthcare professional, these might surprise you because they're common risk factors that we see almost every single day when we treat people with chronic pain. So the first one is insomnia. Insomnia is common among people living with pain, and it's also associated with an increased risk of suicide. The next is an over-reliance on passive coping strategies. When you recognize or observe that someone is hoping their pain will go away from these passive coping strategies, that can increase their risk of suicide. The next is pain catastrophizing, a topic we've talked about in depth on this podcast. All of us are well aware of the pain catastrophizing scale, and there are also other scales and self-report measures that identify catastrophizing, so it's very important that we include that in our initial paperwork. The next is prescription pain medication access when other factors are present. Of course, we're talking mostly about opioids here. And it's not just if someone is taking opioids, there have to be several other factors, the factors that you'll learn about today, present. And as we're talking about prescription medication, always be on the lookout kind of for what they call the triple threat, which is opioid use, anti-anxiety medication use, and alcohol use disorder. So those three together, people oftentimes overdose as well as an increased risk factor for suicidality. There are specific pain diagnoses that have been associated with an increased risk, specifically chronic lower back pain, the diagnosis of psychogenic pain, which is medically unexplained pain or medically unexplained physical symptoms, as well as migraine. So those three, chronic lower back pain, psychogenic pain, and migraines. Feelings of helplessness or hopelessness, individuals who feel that they can do nothing to change or impact their pain and believe that positive outcomes are not possible for them, may be at an increased risk for suicide. And then finally, isolation or perceived burdensomeness. Oftentimes these go together. So if you recognize or identify distress in interpersonal relationships, or someone feels like they are a burden to others, or they express feelings of not belonging, these are associated with an increased risk of suicide. Now, suicide can look and sound a lot like depression. So it's very important that we screen for depression. We all know that depression rates are very high in those living with pain. There's a very simple way that you can screen for depression in your clinical practice, no matter what type of health professional you are. And that's with what's called the PHQ-9. So That is the Patient Health Questionnaire 9, readily available online. If you just Google Patient Health Questionnaire 9, this is a multi-purpose instrument for screening, diagnosing, monitoring, and measuring the severity of depression. It includes 9 questions. What's great about this is not only does it screen for depression, but question number 9 is a single screening question on suicide risk. A patient who answers yes to question 9 needs further assessment for suicide risk by an individual who is competent to assess this risk. That may or may not be you. Hopefully, by the end of this episode, you realize that screening for suicide is possible. What I also like about the PHQ-9 is it gives you a couple different cutoff points for mild, moderate, moderately severe, and severe depression. And then with those cutoff points, it recommends proposed treatment action for each cutoff point. Again, Patient Health Questionnaire 9, super simple, 9 questions to screen for depression. Question number 9 is specifically for suicide risk. Okay, and with some of that background information, let's bring in our expert guest for today, which is Dr. Joan Rosenberg. Dr. Rosenberg is a cutting-edge psychologist who is known globally as an innovator in the field of mental health. She is a 2-time TEDx speaker, along with serving as a blogger for Psychology Today, and has been a featured expert in multiple documentaries on television as well as radio. As a licensed psychologist, Dr. Rosenberg speaks on how to build emotional strength and resilience, psychotherapy, as well as suicide prevention. She's currently professor of psychology at Pepperdine University in Los Angeles, California, as well as maintains an active clinical practice. The aim for today's episode is to create a roadmap or a blueprint for assessing and intervening with suicide. Okay, without further ado, let's begin and learn about this important topic. And let's meet Dr. Joan Rosenberg. Hi, Dr. Joan Rosenberg. Welcome back to the Healing Pain Podcast to talk to us about this important topic of suicide, which has really important links to those living with chronic pain.
Hi, Joe. It's great to be back. Love being here with you.
I know you've done some work in this area on the research side as a clinical psychologist, and of course, working with patients in the clinic in practice. So I'm excited to talk to you because you have that, really nice balance of both. You've researched it and you've also lived this with the people that you help.
Absolutely true. Yep.
I think a good place to start, because we have both people who have chronic pain who listen to this, or loved ones of people with chronic pain, as well as practitioners who are seeing people with chronic pain who are at an increased risk for suicide. I think the best place to start is, how do I identify the warning signs of someone who is planning or contemplating suicide?
The first for me, Joe, is to listen to the language. And I'm listening to language of hopelessness. I'm listening to language of profound sadness. I might be listening to the language of depression. And I will be listening for references, certainly, to suicide. People who would be better off if I were dead. I wish I could go to sleep and this would all be over. Or people who are actually actively contemplating it. So that there's such a wide array of ways to start to attend to people actually feeling to that degree of hopelessness and then considering taking their life.
So as a practitioner or someone who's living with someone who may be at risk for this, it's tuning your ear.
Absolutely.
And listening to what people are saying, either in direct conversation to you or in passing.
Absolutely. And I never, ever, whether I'm out professionally or I'm out personally with somebody, if they use the language of suicide, I actually have a very strong reaction to it, because I don't think it's something that we ought to be taking lightly and just joking about.
Right. Because some people do use it jokingly, like, I've heard this before from, friends and family and colleagues, like, if I just left the planet, this would be so much easier.
Right.
But in a joking way, but we should be attuned to that, basically.
Absolutely. Yes. For me, that's a signal.
Other than language and obviously the cognitions and thoughts that go with that, are there behaviors that a professional or someone living with a loved one can watch out for, behaviors that might change or habits that might change as someone is moving or contemplating suicide?
Yes, I think there's a wide variety of things that we can watch for, Joe. Some people call these risk factors. Other people might call them warning signs. I think we can use the language of either one of those. But certainly one would be watching for depression. So, and when I'm talking about depression, there's really a significant two things that are strong here have to do with isolation and withdrawal, and just kind of a shutting down. And moving away from not only other people, but also moving away from their own experience. That would be one. Certainly increased substance use, and that can come in all sorts of forms, whether it's increased alcohol, drinking to get drunk, and checking out in that sort of way, or checking out in the wide variety of other substances that people can use. I don't know if people have attempted, and when people are in pain, oftentimes there's access to medication, as we know. So whether there's been a prior attempt that's there is a possibility. People have problems thinking clearly, and sometimes that comes with the substance use. Sometimes there's a family history of people who have trouble thinking. So, this would be situations where maybe somebody has bipolar, or some other kind of, or maybe a head injury even. And we know historically now, in terms of what's been in the media about people who've had very severe concussions, that sometimes prompts some kind of suicidal reaction. We know that there's anxiety, there could be agitation, and certainly if there's really bad sleeping habits, and that people are not sleeping well through the night, then that can be also a contributor. On an emotional level, the things I would be looking for would be losses. Has somebody experienced a recent loss? Now, and I think of loss, Joe, as far more broad than just relational loss. And what I mean by relational loss is a relationship with another human being or a relationship with a pet, right? But loss goes way broader than that. And so there could be loss of reputation, there could be loss of finances, there could be loss of health, right? So the chronic pain could be part of what prompts this. The loss of finances, loss of employment, the losses go extensive. So if there's recent losses, then that would be something to pay attention to. If there's an experience of hopelessness, that would be super important to pay attention to. So again, I think I have roughly close to 30, but those are a handful of really important ones.
And the ones you mentioned are really just resonate with all of us who treat chronic pain. When I think back to the pandemic, the first one you mentioned, isolation.
Right.
At one point, obviously, before the pandemic, it was common when people got treated for pain that they came into a clinic, whether it was a PT clinic or a multidisciplinary clinic. And then all of a sudden, that at time, for a period of time, shut down. Luckily, telehealth has proved to be effective for most people with regard to that. So luckily, we have that.
Right.
The second that you mentioned is when people feel helpless or hopeless, and they have items or things around them that they could potentially injure themselves with. Opioids being one. So it's kind of this double-edged sword where people may need opioids for a period of time to help them with their pain, but we should be aware that this could be a potentially negative substance that
absolutely
for danger.
Right.
And then depression itself. Most people with chronic pain suffer from some form of depression. And I'm just curious, when you say obviously depression is a major risk factor, are you saying major depression, or is even middle moderate depression a factor?
More I'm thinking the severity. So when I'm a more severe depression, people, and then it gets a little bit backwards because people tend to lose energy when they're depressed. Yeah. And so people always talk about kind of that recovery period when they start to feel a little bit better, that often becomes a time for planning. And so, but in general, what I'm talking about is when, and there's 8 or 9 different symptoms, if we will, that go into clinical depression, but it would be changes in sleep, in interest, in energy, in concentration, in appetite, and then some sense of wanting to take their life, or potentially, or thinking about that. So I'm talking about the more clinical depression, severe.
I reached out to you weeks ago about this topic because on episode 249 of the Healing Pain podcast, I interviewed a colleague of mine. His name is Dr. Zachary Stearns, who's a physical therapist, and he put out a paper on how to screen for psychological factors when treating people with chronic pain. And specifically, that paper is for physical therapists. It's an excellent paper. I recommend everyone read it and check out that interview, go back. But there's a framework he has in that paper of kind of moving from what we would identify as a biomedical approach to pain toward a biopsychosocial approach to pain, where you're screening for these psychological factors as a PT. In that screening process comes up the topic of suicidality. So screening for suicidality, and then what do you do as a PT specifically if someone says, yes, I have a plan to hurt myself, or yes, I've been thinking and contemplating hurting myself or taking my own life. And in that paper, and he's part of a team, so it's a group effort here, is to call 911. Now, I've read that we should call 911, and I've also read that we should not call 911. I've heard even mental health providers who I know personally and professionally are on kind of, both sides of the seesaw, so to speak.
Right.
So I'm just wondering, what is your perspective? I know you have some research on this and some data probably. Should we call 911 if someone confides in us and says, yes, I have a plan to take my life?
Well, so that if I have a plan, my next question is, do you have the intent? So for me, these get into very nuanced situations, Joe. So can I globally say yes, no 911, no 911? My effort would be to lean on the no 911, and that wouldn't be my first reaction unless there was intent. Having a plan is one thing. Having the intent to do it is something else. And part of the assessment process that I want people to go through is actually assessing thoughts, intent, plans, and means. Right? So I can give you examples of this, but there's a difference between passive and active thoughts of suicide. And certainly there's a difference between intent and plans. And so many times what I will watch is clinicians on every spectrum, whether it's mental health clinicians or otherwise, want to immediately turn to 911 or ER services, emergency room services, as a first response, mostly because we are unable to, one, assess accurately enough, and two, intervene, and three, manage our own anxiety. And that lots of times I think the management of the client or the patient is actually more tied to management of our own experience as opposed to the patient themselves.
There's a whole lot to unpack there.
I understand that.
Which is why I wanted to invite you on and talk about this. Because
right,
as you mentioned, the nuance is what's important though, right?
Right.
So I'm trying to figure out what I want to talk about first, because all of that is just so juicy.
Okay.
This is what I want to talk about first. I want to talk about the practitioner or the clinician's own sense of feeling anxious and vulnerable.
Right. So the first place to start there is that people are not trained well enough.
Yeah.
And there's two pieces to this. One has to do with the literal knowledge it involves to understand kind of the suicidal thinking or suicidal process, or all the factors that are tied into this. Plus this one part of it is the assessment phase of that. The second knowledge piece is the intervention part of that. So those are two areas that are important. The third is, if we don't manage our own unpleasant emotional state very well, then we're typically not going to be all that great at containing someone else's experience. And it might take a simple reflection of feeling back to the patient that actually might calm the patient down, or a few different questions that deepen your assessment that then make a huge difference in calming the situation, in finding out that in fact the person is only thinking, they think occasionally about it, they have no intent, they have no plans, and they have no means, right? And now we're approaching the patient in a very, very different way. It's much more sensitive, it's much more attuned, and much more responsive. And that that many times, and in fact, the early writings and why I wrote the article I did 20 years ago is because most of the literature that existed had to do with what I call action-based interventions. And that to me was all mostly managing the clinician's anxiety and not containing for the client.
Mm-hmm.
It's responding to the feeling state of the client or the patient that I think makes a huge difference in terms of actually responding more accurately to what's going on when somebody starts to talk about pain that then registers to suicidality.
So it's very difficult to put out someone's emotional fire if we can't kind of manage our own.
I think it's
at the same time.
I think it's important that we are able to do more of that. Yes.
Now the assessment part, because people are hearing, so there's three aspects you're talking about here. So there's how do I manage the first, probably the most important part is how do I manage my own feelings as a professional,
right?
As I'm entering into this potentially anxiety provoking situation.
Correct.
2, how do I accurately assess this?
Right.
And the third is the actual intervention part. So where do we go with regard to assessment?
So for me, there's a sequence that I talk about. And certainly if you've had an opportunity to do a thorough assessment, and frankly, I don't care what profession we're in at that point. So whether it's me as a psychologist, whether it's you as a doctor of physical therapy, or it's some other discipline, I think it's important that we're covering these kinds of important questions. So, and most of us will do some kind of an interview or an intake in order to do that. And I think a routine part of it needs to be 2 things. One, and kind of a touching, I know that people touch on pain. I think it would be great if people touched on depression. Mm-hmm. And again, there's knowledge out about how to do that. So we do this interview. Part of that interview is assessing for depression. And another part, and one element of assessing for depression involves suicide, so that we're then also asking questions. And have you ever thought about hurting yourself, taking your life, or completing a suicide? So that it just becomes routine as part of what we ask. And you'd be surprised at how many people give yes answers to that. But a yes answer doesn't mean alarm necessarily. Mm-hmm. And then it might be, all right, well, help me understand that. So that would be the next layer is, okay, let me understand the thoughts that you've had. How long ago did they occur? Right? Or was there ever an attempt?
Right. Because when you're saying you've screened and someone has said, yes, I've thought about this.
Right.
Really, at that point, what you're trying to do as a clinician is to, one, potentially normalize the experience for them, because it's normal that people have suicidal thoughts, right?
It's very common.
Very common. And it's even more common in the populations that we see as health professionals.
Absolutely true. Right? Yes.
And then now that we've normalized that somewhat, how do we move forward from there, basically?
So for me, again, I started to broach it a little bit. And my shorthand for it is to ask about thoughts, intent, plans, and needs. Mm-hmm. So if it actually comes up, then what I want to get a sense of is, one, how long ago were they thinking about this? It could have been years ago. Never happened again. But they said yes to the question. Great. Awesome. Maybe it was a couple of months ago. Maybe it's right now. And especially if it was really recent, or it's right now, then what I'm going to do is I want to deepen that conversation. And so for me, it's then fine. Well, what kind of thoughts are you having? How frequently do you have them? How intensely do they disrupt your thinking, mm-hmm. or disrupt your day, or feel intrusive to you? Right? When you start to have them, how long do they last? Like, are they lasting for, it's fleeting? Or are they lasting for minutes or hours, or seems like it lasts the whole day, right? So there's ways to also deepen just in the understanding of the kind of thoughts. Like I said, are they active thoughts? Like, I actually went out and bought a gun, or I'm going to go drive my car off a given cliff. We've got plan and thoughts in there together. Mm-hmm. Or is it, I just think people would be better off if I were gone. Now, both are important. I'm not going to dismiss the one that it seems a little bit more passive. It's just as important. Why? Because they're having it. And that's going to give me a measure of distress. so then I want to find out about intent. And Joe, this is the one question people have to ask. Absolutely across the board have to ask is, do you actually intend to follow through? And there's no going around you can't walk around this question. There's no circling rose bushes or anything else, right? You have to ask the question straight out, direct. So do you intend to take your life? Do you intend to complete a suicide? Do you intend anything that smacks of that? It's got to be asked directly because we need to know intent. And the intent question is the one that leads us more towards 911. Mm.
So the intent question is the one that leads us to 911. That's great. And that's the answer that really everyone's looking for.
Right. So if it's a yes, then the next question you want to find out about is imminence. Mm-hmm. Now, I've had people say yes to that question, but the response, I'll give you an example of a response was, but I wouldn't do it until I paid off all my debts, because they didn't want to leave people with the debts. And when evaluating for that, it came out that would be 6, 9, or 12 months later, then imminence is not an issue. The intent was, but imminence wasn't. So with the intent question, the next thing we want to know is imminence. Those two pieces are part of what leads to 911.
I like these frameworks you have because it really helps everyone see, okay, how can I embed this really in my evaluation? So in general, I'm screening for psychosocial factors.
Correct.
In chronic pain, there's many that we screen for.
Absolutely.
Fear, anxiety, but you mentioned depression, right?
Right.
And we screen for that as PTs all the time.
Right.
As part of a good quality, evidence-based, validated depression screen, there should be something with regard to suicidality in there.
Yep. And
then you have this intention that we're looking for in part of the patient interview, so to speak.
Absolutely. So if there's any expression of suicide, then I'm deepening the conversation to the next level, right? And the next level are these thoughts, intents, plans, means. If it's intent, then we add imminence. How quickly is someone intending on responding? I've had same thing. I've had somebody say, yes, they had intent. He was a scuba diver, but the issue was, when was he next going to go scuba diving, right? And could we work within that time frame and before he ever did that again, right? So there's many different ways to start to listen and hear that even though there might be intent, there is not imminence, so that the threat is not there. And then what I want to find out does someone have the means available? Do they have plans? And then do they have the means? And again, I'm asking the questions directly, and I am also listening for the kinds of answers that are going to suggest to me that it's closer as opposed to farther away.
I guess I'm assuming a question people at home listening and watching probably want to know, if someone has an intent and imminence, how likely are they to, and maybe there's a stat on this or this, how likely are they to share that information with you?
80% of the time, the suggestion in the research is that 80% of the time people are going to give you signals or signs. 20% of the time, people won't do that. And it's that 20% that none of us can help. They're very clear about it. They're very intent on it. And even if you ask, they'll tell you no, and then they'll follow through anyway. So it's on our end as clinicians or family members, frankly, it's living with the helplessness that evokes. And it evokes a profound sense of helplessness in all of us. Don't think that clinicians don't feel that. Clinicians absolutely feel it.
And it's normal to feel vulnerable as a clinician if you don't have the proper training, right?
Absolutely.
Right.
Yeah. Yes.
That's why when I saw that in the paper, I deeply appreciate my colleague for, opening the conversation up about that, which is, as you know, a research paper is limited in words and content and what we can do. So right. I appreciate the conversation, and I'm like, okay, it's great, but there's more to it than just refer to 911, obviously. What's the risk if someone does, a practitioner does, call 911? What's the risk to the patient at that point if they don't have that intent or that imminence?
Well, there's a wide variety of things. One, you're boxing the individual in, and that's not actually emotionally where they are. So now they've been up-leveled into potentially a system a medical system, or it can have other implications as well for careers, depending on who they are. And so now they're boxed into that system. We were talking earlier, a hospital might not have beds. Psychiatric hospitalization isn't what it was 20 years ago or 30 years ago. And so people don't actually get the benefits of a long-term treatment if it's truly needed. And instead, they're in a short-term system that gets turned over anywhere between 24, 3 or 14 days, 24 hours, 3 days, or 14 days in most states. So what I was telling you earlier is that hospitalization doesn't decrease risk. The research suggests that hospitalization just contains risk. So now somebody's in the hospital, now they have to deal with the stigma, they have to deal with medical costs, they have to deal with an array of other experiences that actually might be meaningless in relation to what their genuine experience was in even telling you that they were suicidal.
Can you tell us a little bit about that paper that you wrote and the findings that came out of that, and how it's really, I know obviously you teach this
right.
at Pepperdine to your psychology students, but it's informed your work in many ways.
You're talking about the 1999 article? Yeah. No. Again, what I found there is that, and what I wrote about when I first started to address this issue, was that more of what was contained in the general psychology literature or research literature at that point were suggestions about what a clinician should do when somebody was suicidal, and less of it. So it was more all the action-based kinds of things. And my impression was it really was designed to more contain the experience of the clinician, but it didn't seem to be addressing the experience of the client or the patient. And so my focus was to dial into what I called feeling-based interventions as opposed to action-based ones. And the feeling-based interventions really were to focus in on the patient. Now, Edwin Schneidman, who was considered one of the leaders in terms of the field of suicidology, used to call suicide psychache. So it's totally in line with this. And that's really what I found, is that the part of the way that I look at suicide, especially if there's moderate to low risk as opposed to high risk. So the high risk we're talking about maybe severe depression, might be thinking difficulties, might be a whole array of things where there is also intent. Those are going to be high-risk people. Those might be the people that, again, will go 911 and will focus on action-based strategies, perhaps almost entirely. But when there is moderate to low risk, so imminence is not, the intent is not there. Maybe there are thoughts and plans, but there's no means and there's no intent, or it's even less than that, then I'm going to go for some mix of action-based plus what I would call feeling-based interventions. And so the first thing that I want to do with somebody is basically to thank them for being honest about their experience. It's like, and what I will say to them is, you know what? One, I'm really glad that you're here. Second, I'm really glad that you're talking about this, because what it suggests to me or tells me is that not only do you have the desire to live, you have the desire for help. Or I might do it the other way around. You have the desire for help, and you also have the desire to live. So, and I'm going to frame it that way in part because I want them to get the message. That's what talking about it and making it open so others can respond and others can help, that makes a difference. And that to me is a signal that they want to live. The second is, I think there's, 8 or 9 that I have written in that particular article, but the 3 that I want to highlight, that's the first one. The second one, oddly enough, Joe, is to convey to people that there's a difference between ending one's life, and a desire to end one's life, and a desire to end one's pain. And it's so interesting because people don't necessarily make that distinction. They're in pain, and the only solution, because they're in so much pain, and this could be physical or emotional, that they go, got to end my life. And it's like, no. There really is a difference between the two. And sometimes just offering that up makes a difference in terms of someone shifting their experience. Like, oh, okay, you're right. It's the pain I want to end. It's not my life I want to end. And most of us don't want to end our lives.
A nice distinction and create some space between the two experiences.
And surprisingly, people don't think about that.
Mm-hmm.
The people in pain.
I know. I was just saying, I really like that. It's very, I think it's subtle, but it just helps people, again, create some mental space between two potentially different experiences for them.
Correct. Right. And then the third one to me is really the one that is the most important. And what I started to hear when people were suicidal is that, and again, if I go with Dr. Schneidman's response of psychache, it's like we don't have a word in our language that captures the depth of pain we're in. So when people start to use the word suicide, that's where my brain goes first. It's like, oh, they're not feeling a little blue. They're not feeling a little down. They're not feeling right? Nor are they necessarily feeling profound sadness or profound disappointment. They are in such depths of pain that the only word they can use to capture that depth of pain is the word suicide. So part of it, when I teach about this, or train others, again, it's been mostly clinicians, what I will talk about is that, and I'll write on the whiteboard, suicide equals act or action. Then I'll put one of those slash marks through the equal sign and go, no. Again, when moderate, low risk, suicide equals a communication. It's a communication. It's a signal about the depth of typically unbearable or intolerable pain that I'm in. So then what I will do is I'll talk to the patient about this, and I'll say, look, this is what I hear you communicating, that the only word you have to capture what you're going through is to tell me that you're suicidal. That gives me an idea of the depth of the pain that you're in. And what it's also telling me is that it feels unbearable or intolerable to you. Mm-hmm. But what I'm going to ask you to do is that when you leave our room where we are, or we can virtual or otherwise at this point, is I want you to switch out the word. So anytime you think the word suicide, or anytime you think about taking your life, what I want you to do is to shift it over. So now we're not talking about life or death. What we're talking about is finding a way now to help you either manage the pain or end the pain that you're experiencing. And people really wrap their heads around this and find it really, really useful. It's like, oh, okay. And in fact, I had a grad student years ago come up to me probably 10 years after he graduated his doctoral program and look at me and say, Dr. Rosenberg, I just want you to know, he wanted to talk to me. He told me that I'd saved his life. It's like, what are you talking about? I saved your life. He was in a class where I taught this material. I did not know he was suicidal. He never told anybody, but he would continually remind himself that it was about the emotional pain he was in, the unbearable pain, and it wasn't about taking the action. And that's what he used to get him through till he was on the other side of it. I had no idea, Joe.
I like that, because the words hopeless and helpless have never seemed quite appropriate to me, especially when you start to talk to people and they start to tell you what their life is like, what they're experiencing, what they're struggling with. But really what you're saying there, what I like what you're saying is that you are helping facilitate a sense of hope in them.
Correct.
That currently you're seeing suicide as the way out almost. You can't see anything else. But there's this space between where we can help you manage, alleviate, relieve a lot of what's happening.
Correct.
So that now we can start to see a life that's there.
Absolutely true. Yeah. And so the thing that I would say here is that, and what I advocate is that there is some proportion, some mix, some balance of action-based and feeling-based interventions. And I will never know what that balance is, because those are the nuances tied to the individual that's coming in and saying, this is what I'm experiencing. So it's understanding that there needs to be some mix of the two. The proportion is going to change based on the individual.
I know negative self-talk and self-criticism is something you talk about often. Shows up all the time in the clinic.
Yes.
How does that relate to this topic?
This is a big one, and I have no way to prove it at this point unless I were to go out and do a study. So we should think about this one. I actually think that harsh self-criticism is one of the most important contributors to suicidality. that it's the takedown. So if we're in a wrestling match or some other kind of encounter, that this is the thing that this is the punch that knocks people down to suicidality.
And it's a wrestling match with ourselves.
Yes. So I'm when I am working with somebody and I'm first meeting them and I hear layers and layers of harsh self-criticism, I will tell you I've now shifted part of the way I practice to making efforts to help them end the harsh self-criticism first, so that we actually have the space to work on other stuff. And harsh self-criticism in general, I look at as a distraction from unpleasant feelings. So it's, for me, harsh self-criticism is a thought hijack of unpleasant feelings.
How is it a distraction? So can you give us an example of that?
Really easy one. I was doing an interview similar to what we're doing today. I could hear the other person. He could not hear me. And I'm watching him, trying to do all this stuff on the keyboard, and well, that's not working. And then I watch him dip down, and you can imagine he's now crawling underneath. I can see him crawling underneath and playing with the chords, right? You got the whole picture. And so this is like going on for a few minutes. I'm totally chill. I'm fine. I'm not saying anything. I'm just waiting. And out of his mouth comes, "I'm so embarrassed." Without missing a beat, he says, "I'm so stupid. I'm such an idiot." Yeah. That's the thought hijack. Embarrassment would have been fine, right? But no, it didn't stop at embarrassment. It went to, "I'm the idiot. I'm stupid." That's the distraction from the embarrassment. That's the thought hijack,
right?
Of the embarrassment.
Yeah. It's not that the difficult or unpleasant feelings he was having at that point of being embarrassed are necessarily the problem. It's how the thoughts can have a consequence on his behavior in that moment, or even later on throughout the day, throughout his life.
Absolutely. Because now that becomes the talk. And I will tell you that harsh self-criticism and unpleasant feelings are not equal. There is zero equivalence there. Harsh self-criticism is, think of an elevator tanking.
So it can take you down really fast.
Absolutely. And depending on how much you do it, how intensely you do it, how frequently you do it, it's just, then you're coloring your whole experience in a profoundly damaging way. And what we know is that this kind of thinking also promotes more pain. So there's an intersection between how we treat ourselves from a thought and a feeling perspective that contributes to more pain.
That's why I love mindfulness so much, because aspects of mindfulness, no matter what type of mindfulness-based approach you study, really are a lot about letting some of these feelings, difficult sensations unfold, right? And realizing there's also, with the body component, there's also a mind component that happens, and how those two interact, and how you can create that space and interrupt that automaticity that we're really talking about, that steamrolls in people with depression, people with chronic pain, a lot of the populations that we see.
Exactly.
Yeah. And that's why I was doing some research for this episode, and pain catastrophizing is all over the literature with regard to chronic pain, but it comes up with everything. It's one of the highest risk factors for chronic pain is pain catastrophizing. And really it fits in so well with what you're talking about with regard to negative self-criticism.
Right.
It's a form of rumination, right?
Right. Yeah. The other thing that I didn't mention that is worth also mentioning is the unresolved trauma. So that the trauma is a contributor. And so that if there's leftovers that people also need to address, if those can get addressed, sometimes that also makes a difference in relieving some of the pain, the physical pain.
Yeah. Any comments or suggestions for clinicians who want to receive more training in this area, who want to brush up or learn about the latest evidence-based research, things like that?
I mean, what I would do is probably, believe it or not, encourage people to go back to the 99 article. It's in Professional Psychology Research and Practice. That's where it was published. And it's basically a suicide assessment and intervention, and it has to do with action-based and feeling-based interventions. I think that's a nice start. Bruce Bonger has written a lot in this area. There's David Jobs There's a wide variety of authors who've also written in this area, so that they can go to some of those materials. The training is out there, but the important thing is getting it so that you actually, with increased knowledge, then it's going to make a difference in terms of your more accurate and more attuned response to the suicidality.
And just tell us again the title of your paper and the journal it was in.
It is in the Professional Psychology Research and Practice, Suicide Prevention, an integrated training model using affective and action-based interventions.
Excellent. We'll make sure to link to that in the show notes so everyone can access that.
Okay.
Dr. Joan Rosenberg, it's always a pleasure to speak with you. I know you have lots of other great stuff in the realm of anxiety and unpleasant feelings. You have 2 TED Talks, you have multiple books, website, your own podcast. Let people know how they can learn more about you.
And certainly if they go to drjoanrosenberg.com, that would be a first place. Or if you go to YouTube, there ultimately will be 3 TEDx up there. I'm doing one on imposter syndrome coming up in the next couple of days. So it'll be a TED Salon conversation. So YouTube, there's all sorts of, YouTube will carry you to all sorts of podcasts and other information. Certainly you can reach out to me through my website directly. So that's, if people want to reach me, I'm very findable.
Excellent. So again, you can reach out to Joan and learn all about her work, her books, her products, her programs at drjoanrosenberg.com. That's drjoanrosenberg.com.
Right.
Or you can search on YouTube.
Or all the social media. I'm on Instagram and Twitter and those places as well. So I can be found there too. And usually Dr. Joan Rosenberg is the handle for most of that.
And if you're on Instagram, we'd love if you take a screenshot on your phone of today's episode, and you can tag both myself and Dr. Joan Rosenberg on Instagram, and we'll make sure to reach back out to you. Again, if you're someone who is struggling with suicide or needs help, you can always call or text the National Suicide Prevention Hotline at 1-800-273-8255, where you can talk to a trained professional and receive immediate support. I'm Dr. Joe Tatta. It's been a pleasure being with you this week on this important topic, and we'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit Integrative Pain Science Institute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.